So hi guys, welcome to this class. So in this session we are going to discuss most important topic. I think let me give you 2 to 3 4 minutes so that you guys can join fast. So we'll begin the session. So I think my voice, everything is fine, right? So I think everything is fine. So I will give it 3 to 4 minutes so that you guys can join. And I have shared my link also in what's our WhatsApp channel. So you can join by through that link. And I will be providing the notes and PDF in same group itself after the class. So let me wait for 3-4 minutes. Hi everyone. Hello Artik and Sri Lakshmi also. I think how you guys are preparing for your upcoming exams. Yes, fine. Okay, let us wait for 1 to 2 minutes. Like we'll start our session in 3-4 minutes. So my screen and audio, everything is fine. I hope so. If everything is fine, please thumbs up in comment section. Okay. Okay, let's start our session now. Let's begin our discussion. So let's begin our discussion, and I think I welcome you all to one of the most beautiful platform, that is MedCatalist. So in this session we are going to discuss about one of the most important topic, not only for your Norcet exams, like for in general practice also. This subject will be very helpful, and this topic, especially this topic, is like you should know about each and every aspect regarding to diabetes and management and all. We will cover all the aspects related to these conditions. So let's begin our discussion. So everything is fine, I think so. Okay, let's begin our discussion with today's topic, diabetes. So what actually happens in diabetes, type 1 diabetes, type 2, and I will be teaching in an integrated fashion, such as like I will be integrating some medicine concepts, pharmacological concepts and your biochem concepts also over here, so that it will be helpful for you. So let's begin with topic diabetes. So let's discuss some general topics. Like diabetes is nothing but but India has become like one of the top country in the world in diabetes. Like India is the first country which stands in diabetes, and if you take the Indian population, like 11% are suffering from this disease, that is diabetes. So like what actually happens in diabetes, we all know, right? Like increase in the blood glucose level. What actually happens here is there is an increase in blood glucose level. So how it will be increased, and let us discuss about what actually happens in diabetes mellitus, right? So we all know, like in our body, pancreas is present. So pancreas has different types of cells, that is alpha cells, beta cells and delta cells. Okay, alpha cells will secrete glucagon and beta cells will secrete insulin, right? And delta cells will secrete an hormone known as somatostatin. And this is the basic physiological concepts about how insulin is secreted. We all know, like in type 1 diabetes mellitus, there is an improper formation of this insulin, right? These beta cells will get destroyed. So I will be teaching about that. So what actually happens, let's discuss over here. Like diabetes mellitus is a metabolic disorder. As I told you, like in earlier slide also, there will be an increase in the blood glucose level. So let us see what happens in this condition in diabetes. Suppose, imagine this is our blood vessel and this is the cell, right? So what is the main function of this insulin is, insulin helps in transport of glucose from this blood to this cell. Like here, after having a meal or something or lunch, glucose, this carbohydrates consumption leads to, end product leads to the glucose formation, and glucose, whenever it enters into the blood, it will go to the cells, right? So this is the function. This transportation is done by insulin, right? So that's why in type 1 diabetes mellitus, this insulin is not at all present. So that's why blood glucose levels will get elevated here, right? So major normal function of the insulin is to transport of glucose from blood vessels to the cell, and glucose is stored in this cell in the form of glycogen. Okay, this is the storage form of glucose, storage form of glucose, where inside the cell. Okay, so remember, whenever in the blood the glucose levels are increasing, it will damages your eye, and it will also damage your kidneys, and it will also damage your neurons, right? So this condition is known as, like, if the blood glucose level is increasing day by day, that leads, it also affects your vision. So that is known as diabetic retinopathy. And if kidneys will get affected, that is nephropathy. And if nerves get affected, that is neuropathy. So we will be discussing in the complications also, like what actually happens about in diabetic retinopathy, nephro and neuro and all. So like this is, and now let's discuss about types. So in types, first type is like type 1 diabetes mellitus. Type 1 diabetes mellitus. I think my speed is, everything is fine. Let you comment, you guys comment. Everything is fine, right? Okay, let's start. In type 1 diabetes mellitus, what is the actual problem over here is the body's own cells will destroy the beta cells, right? So I thought like here beta cells will get damaged. Here beta cell will get damaged, right? The body's own autoimmune body, like this is an autoimmune condition where the body's own antibodies will destroy these beta cells. Antibodies will destroy this beta cell. I thought like here also in basic also like beta cells will form the insulin, but whenever due to some autoimmune conditions or some viral infections also like this beta cells will get destroyed. As a result, there is no production of insulin. There is no insulin production in this condition. Like so, like what is the major drawback of this disease in type 1 diabetes is like in after 80% destruction of the pancreas only you will get the symptoms of an hyperglycemia. So that's why this is very dangerous condition, and it is seen in pediatric onset. It is seen in pediatric onset. So what is the drug of choice is here is insulin, because like insulin is not at all produced in this condition, no. So that's why there is no role of oral hypoglycemic agents in this condition. So after 80% of your pancreas will get destroyed, then only symptoms will appear in this condition. And in adult also some autoimmune diabetes is also present, that is known as type 1.5 diabetes mellitus. So this is also known as LADA, that is latent autoimmune diabetes in adults. The autoimmune antibodies in the adults, if it destroys your beta cells, that is your LADA, and in pediatric age group, if the beta cells will get destroyed by antibodies, that is in type 1 diabetes mellitus. If the same, everything is same, in adult it is LADA, in pediatric it is type 1 diabetes mellitus. So let's go for most common diabetes overall is type 2 diabetes mellitus, and this is the most common diabetes mellitus. So here remember, here beta cells are completely fine, pancreas is also producing insulin, right? Insulin is completely perfect over here, but here the problem is in receptors. Receptors do not function properly. So what actually happens here is, like which I taught like from the blood the glucose will be transferred into the liver, skeletal muscles and adipose tissue. Remember, from the blood same glucose it is going to liver, adipose tissue and all, right, from rest of the organs. When insulin is getting the glucose, here some receptors will be present on the skeletal muscles and all, right? Here some receptors will be present. What actually happens here is, due to some conditions, these receptors will get damaged. This receptor is like key. Receptors function is like a key function. So whenever glucose is coming, these receptors will open the door and the glucose will enter into this liver or into the skeletal muscles. Okay, this is the function. When receptors will get damaged, the glucose level will get elevated in the blood. Okay, so that's why it is also known as insulin resistance. Type 2 diabetes mellitus, here it is insulin resistance. So that's why if you check this RIA levels, radio immunoinsulin assay levels here, right, it is completely increased. Insulin is fine over here, but receptors is not functioning. But when you come to this type 1 diabetes mellitus, if you check this insulin levels, it is always less. Okay, and this is the difference between type 1, type 1.5 and type 2 diabetes mellitus. And next, one more condition I want to explain is MODY. MODY type of diabetes, MODY. It is also known as maturity onset of diabetes in young people. Okay, and this is about Modi. What actually happens in this condition is like his grandfather, it is an autosomal dominant. It is an autosomal dominant. So what do you mean by this is like his grandfather is also having diabetes and his father is also having diabetes and he is also having diabetes. So why I have mentioned this young people is like this guy, he doesn't have the symptoms, but when he go to this checkup, right? So nowadays like in offices and all, they will be doing this free blood glucose checkup and all, and you saw that his blood glucose level got elevated. Blood glucose level got elevated and it is about 200 and all, and he is denying like I don't have any previous history like polyuria, polydipsia, all the symptoms is absent, even though like he is having the blood glucose level is elevated. So symptoms is absent. So this is known as MODY, maturity onset of diabetes. This is an autosomal dominant pattern. So this is an inherited from the grandparents and fathers and all. So this is about MODY, and this is in young onset, like in 25 also, and you can see it in the 35-year age people also, right? And this is about types of diabetes mellitus. Let me glance you for you. Type 1 is pediatric onset, and type 2 same autoimmune antibodies, they are destroying your beta cells. So that's why insulin levels is not at all produced over there. So that is about type 1 and type 1.5. And next, when you come to this type 2 diabetes mellitus, everything is fine, but your receptors is not functioning properly. So that's why I can give this oral hypoglycemic agents in this condition, because insulin is absolutely fine over here. And MODY we know, maturity onset of diabetes in young people. So what actually happens in this condition and all? So like there are few tests like recently we used to get in some of the exams, like if you want to measure the insulin resistance, right? So like this MODY guy, like which I told you, this young guy, he can come to you, and if he tell that my grandfather is having diabetes and my father is also having diabetes, so like he is not diabetic, and if he want to know that is there any chances he can get the diabetes, is like what test you are going to do is like HOMA-IR. HOMA-IR. And this is like used to measure whether the person is developing this type 2 diabetes mellitus or insulin resistance or not. Okay. What do you mean by this HOMA-IR is nothing but homeostasis model for assessment of insulin resistance. Okay. And one more test is done, that is quickie. So both are used to know that insulin resistance. So what do you mean by this quickie is quantitative insulin sensitivity check index. Okay, these are the tests. And next we move to the symptoms. So what are all the symptoms? Very important, like polyuria, you can see excess urination. So your urine output will get increased in diabetes. So that is greater than 3 liter per day. And you can see polydipsia. So what do you mean by this polydipsia? Water intake is greater than 6 liters per day. Okay. So can you tell me that what is the normal urine output, like 1 ml per kg per minute, right? So average, if you take this 60 kg per person weight, and if you calculate, the normal urine output will be like 1500 ml per day, right? So here it is like 2x or it may be 3x also, like 3 liters, and polydipsia like 6 liters per day. And you can see this weight loss. Okay, and I will write it in a different color. So this is very important. Polyphagia, right? Polyphagia is not a classical symptom. So like why it is not a classical symptom, polyphagia is not a classical symptom is like because like you can eat the food extreme when if the food is too tasty, even we will be eating more amount of food, right? So this is not diagnosed in this condition. So that's why polyphagia is not used in this condition to diagnose this. And the patient, remember this is very important, polyphagia is not a classical symptom of diabetes mellitus. So they can ask you in like all of the following are the classical symptoms of diabetes mellitus except that is polyphagia never seen in this patient. And next is like the patient may develop urinary tract infections and vulvovaginitis. Okay, and these are all the symptoms of diabetes. And next we move to the diagnostic criteria. So in diagnostic criteria, so this table is very important. So this table you should keep it in your last minute revision notes. So first you are going to check fasting plasma glucose level. Fasting plasma glucose level. Okay. And next you are going to give 2-hour plasma glucose. You are going to check 2-hour plasma glucose. So how? By giving this 75 gram glucose to the patient. Okay. So let me write the normal values and pre-diabetic values, and next is like diabetic patient or diabetic mellitus criteria. Okay. Normally for normal person in you and me, if you are not diabetic, the fasting plasma glucose will be less than 100. Okay. And if your value comes between 100 to 125, that is your pre-diabetic. And if your value is greater than or equal to 126, that is the diabetes mellitus in this patient. And after this you are going to give 75 gram glucose to the patient, right? But major advice what you are going to tell to the patient is like after taking this 75 gram glucose, he should not able to walk or he should not walk, because he can comfortably sit in a chair and he can watch his phone also. Like because what happens if he walks, right, that muscles will consume the glucose and the values will get affected, no, like you can get the low glucose levels and all. So that's why you should tell the patient after giving this 75 gram glucose, like he can comfortably, he can sit it in near your lab and he can watch something on phone in the phone also, right? So this is the, you should tell the patient like not to walk more. And if you 22 hours plasma glucose value or 75 gram glucose value, if it comes under less than 140, that is normal. And if your value falls between 140 to 119, that is known as impaired glucose. It is also known as impaired plasma glucose tolerance. Okay. And if your value is greater than 200, and this is a criteria for diabetes, very very important, please don't forget these values. So not only for your exam point of view, and in your general practice also this will be helpful. And if your value is between 100 to 125, don't answer and come impaired glucose. This is an impaired impaired fasting glucose. Okay. And don't confuse with postprandial. Like postprandial is something like if the patient will have complete, he go to the home, he will have the breakfast and he will come back, that is the postprandial value. Okay. And next one more value is like HbA1c, glycosylated hemoglobin, very very important, and this is the best test for to determine the patient is having the diabetes or not. And next test is HbA1c, this is also known as glycosylated hemoglobin. Okay. So if the value falls between less than 5.6 and if this is known as normal, and my value if it falls between 5.6 to 6.4, then the patient is in pre-diabetic, impaired glucose tolerance and all. And if the value it is greater than or equal to 6.5, that is the patient is having diabetes, greater than or equal to 6.5. Like remember this value 5.6 and make it ulta of this, then that will come to your like diabetes in this patient. Okay, this is a very important table, please don't get forget. So I would like to add one more point about HbA1c value is this is an retrospective test. So what do you mean by the retrospective is like imagine like if a person will consume like low glycemic index food at the night, like such as ragi and all, and morning time definitely his blood glucose value will show less, right? But this HbA1c, it will tell the blood glucose value of last previous 3 months, right? So since it doesn't affect with the recent meal intake, so whatever meal you can take, you can eat all the sugar containing sweets and all, but your HbA1c value will give the true value. Okay, so that's why this is the best test to measure the person is having a diagnostic test for diabetes mellitus. Okay, if the HbA1c value is 6.5 and if you want to know in terms of mg per dl, so all these values will be in mg per dl itself, right? Okay, so HbA1c value, if you multiply with 21, then the whatever value will come, that will be in the form of mg per dl. Okay, so like if you like 21 into 6, so 126, right? HbA1c value is 126. So like value is 126 mg per dl. So then you came to know like where the criteria will comes over here, right? And this is the how you will measure the HbA1c value. This is a retrospective. Recent food intake doesn't matter to this patient. Okay, and this is about tests which are going to perform in diagnostic criteria, like how to check the fasting glucose and how to check this 2-hour plasma glucose and your HbA1c. And next we move to the diagnosis of how you diagnose the diabetes mellitus, right? According to American Diabetic Association, like how you can diagnose, the person should be have these symptoms, right? So what are all the symptoms? I thought you know polyuria, polydipsia, weight loss and all. The person is having symptoms of hyperglycemia and you check, symptoms of hyperglycemia and you check random blood sugar is greater than 200 mg per dl, then the person is having diabetes. So this is like previously they used to do this, they used to use this method like RBS, and if the person is you ask the patient that he is having any symptoms of hyperglycemia and all, but nowadays like you cannot wait until the patient will develop the symptoms, no, it will worsen the condition. If asymptomatic patient will come to your clinic, if asymptomatic patient he came to your clinic and you made fasting plasma glucose value, it is greater than 126 here, which I have taught you know, and 2-hour plasma glucose value is greater than 200 mg per dl, then the patient, you can diagnose the patient is having diabetes. You need not to wait until or unless the patient is developing the symptoms. And next is like asymptomatic patient, he came to the hospital and he had everything like sweets and all, and you check, you are going to check here, it's like you cannot check this 2-hour plasma glucose and all, right? That will definitely it affect the sugar value. You are going to do this HbA1c value. I already taught you what is the criteria for diabetes, it is greater than 6.5. Okay, so these are all the values that you should keep it in your mind, like how do you diagnose this? This is very important. So you can expect this kind of questions in the mains also. So this is about diagnosis of diabetes mellitus. And next, which postprandial value is not used in diagnosis? Okay, it is not used in diagnosis. This is the major point. And next we come to the complications. What if diabetes is not treated in the patients? You can get these microvascular complications and macrovascular complications. So Microvascular complications are nothing but your diabetic retinopathy, and diabetic nephropathy, and next is diabetic neuropathy. These are all microvascular. So among these, overall, which is the most common complication is diabetic neuropathy, right? Okay, this is the most common complication. And when you come to this macrovascular complications is like coronary artery disease. Person may develop coronary artery disease such as MI or an angina. Okay, and the patient he may develop peripheral arterial disease. Okay, so this leads to the formation of gangrene in digital gangrenes. Digital area or distal areas, it also leads to the formation of gangrene in this patient. Okay, like distal gangrene and all in distal parts. And next, this is about diabetes and diabetic retinopathy. So let me discuss 2 to 3 points about this diabetic retinopathy and all. Diabetic retinopathy. So here your vision will get affected. So what is the earliest finding in diabetic retinopathy is microaneurysm. Okay, this is the earliest finding. On fundus examination, you can see this microaneurysm. Okay, this is the earliest finding. And what is you are going to treat this like by giving this? There are 2 types of a diabetic retinopathy. One is non-proliferative, and one is proliferative. Okay, and here it is like there is a formation. Diabetic retinopathy is also like this leads to the formation of new blood vessels, that is known as neovascularization. Okay, so how you are going to treat this condition is by through photocoagulation, or I can give this intravitreal injections also, such as bevacizumab and all we will be using. So this I have discussed in my opthal sessions also. Like this is about diabetic retinopathy. This you should know what actually happens, earliest finding and neovascularization, formation of new blood vessels. This is about diabetic retinopathy. Let me teach you about one more aspects like diabetic retinopathy or neuropathy also. So next is diabetic nephropathy. So what happens in this condition is like your GFR will get decreased less than 30 ml per minute. Normal GFR is 125 ml. Here it is decreasing over here. Okay, and this is about diabetic nephropathy. And overall most common is diabetic neuropathy. Here nerve fibers will get affected. So one is your sensory and next one is motor. Okay, so what actually happens in this condition is like you will get this burning sensation in your foot, and there will be some pain also, and especially in the night time you find like burning sensation in the foot due to this diabetic. If diabetes is not controlled, it will damage your nerves also, right? So this is about diabetic neuropathy. So what you are going to give or treat here is like gabapentin. Like for any nerve pain we will be giving this gabapentin. Okay, and this is about diabetic retinopathy, the neuropathy, nephropathy and retinopathy. Okay, overall which is the most common? Neuropathy is the most common. And until here I think everybody got understood. If any doubts you can ask me. So now we will move to the treatment aspects. So until here everything is fine. If you have any doubts, you can ask us. Everything is fine. I think everybody is getting understanding. So if anything, any doubts is there, I can explain you now. So any doubts? I think I can proceed to the treatment aspect also. Okay, now we will move to the treatment aspect. Okay, let's move to the treatment aspect about what are all the treatments you are going to give in diabetic patient. So if you want to know this mechanism of an insulin, so you should know, like insulin, we all know it is given in diabetic patient. We know diabetes is an what kind of a disorder? It is an metabolic disorder. So I will teach you what do you mean by this metabolic disorder. Okay, so listen carefully. So what actually happens here in diabetes is there is an imbalance. So in you and me, like if you are non-diabetic, there is an balance between these catabolism and anabolism, but in diabetic patient this balance is lost. So this coordination is lost. So that's why there will be an increase in catabolism and there is decrease anabolism. So what do you mean by this catabolism? Anabolism is like which factor is responsible for this anabolism is, remember, whenever in our body insulin levels will get decreased, right, that is known as anabolism. And in what happens in catabolism is like stores will get breakdown. I will explain what do you mean by these stores. Like remember, like insulin, what it is doing, it is decreasing the anabolism and contrarily there is an increase in catabolism. So that's why this is known as metabolic disorder. There is a lack of coordination between catabolism and anabolism. Okay, so stores will get breakdown. So what happens? So what is this stores? Let me teach you about this pathogenesis over here. So look at this liver. I taught you know liver glucose will store in liver, adipose and in muscles. Okay, in liver what will be happen, like glucose will go to and there will be an glycogen. Liver is an glycogen storage, no, so there will be an glycogen breakdown. So why it is breakdown? There is an increased in catabolism. These are the stores. The stores will get overactivated. So glycogen breakdown will happen. Whenever there is an increased adipose tissue formation, like there will be an increased lipolysis. Fats will get breakdown. And whenever there is an increased metabolism, the proteins will get breakdown. Protein breakdown. We all know, like in end product of the protein breakdown, we will get the glucose, right? So that's why in the diabetic patient there will anyhow whatever, look at the condition in the liver, the glycogen breakdown will happen, that will leads to increased glucose, and here in the muscle also protein breakdown will happen, that also will leads to increased glucose. So this is an aspects that are responsible for your gluconeogenesis, right? So this is actually happening over here. So these are all these factors, these will raises the blood glucose level. So that is known as stores breakdown. So you are increasing the blood glucose level by through this breakdown of this liver, adipose tissue, muscle and all. Glycogen is getting breakdown and fats is also getting breakdown and proteins is also getting breakdown. So that is about glycogenolysis and gluconeogenesis and all. Okay. So this is about what actually happens in mechanism of an insulin. And now let us try some, like, what is the treatment for type 1 diabetes mellitus. Drug of choice is definitely insulin. Why? Insulin is not at all produced over here. And in type 2, drug of choice is metformin. So insulin you can give it last. Okay. And if they ask you like oral hypoglycemic agents, they can be given in type 1 diabetes. First you should give insulin, and after that there are only 2 oral hypoglycemic agents which can be given in type 1 diabetes mellitus. Remember, that is like acarbose and pramlintide. Okay. So these are the drugs which you are going to give in type 1 diabetes mellitus. So remember, first is insulin, and next if they ask like add-on drugs, you can go for acarbose or pramlintide. And next in type 2 diabetes mellitus, drug of choice is metformin, and you can give like all other oral hypoglycemic agent. Then also if blood sugar is not controlled, last is insulin. Okay. So this is about treatment. So most of the students, they will be confusing like how basal insulin, bolus insulin and all. So let's discuss. Insulin is very important. You may get the questions in the insulin. Okay. Sorry. So I will explain what is the basal or bolus dose. Suppose imagine I am taking breakfast and I am having lunch and I am having this dinner also. Okay. So what actually happens is, whenever I take my breakfast, body's insulin, right? Insulin, there is an increase in blood glucose. So that the body will neutralize the blood glucose by secreting the insulin. This is the function of the insulin, no? To decrease the blood glucose. I have took the breakfast, automatically my blood glucose level will get rise. So that's why body will produce the insulin, so that insulin will get that will decreases the blood glucose. Same thing will happen when I will consume this breakfast, lunch. I took the lunch, glucose is getting elevated, body will own mechanism, insulin will get released. So that will decrease the blood glucose level. So this is known as peak insulin. Insulin activity will be peak over here, and this is also known as bolus insulin. Bolus insulin is the insulin which is released after taking your food, right? After you had the food, your glucose is rising. Which type of insulin come to the action is bolus insulin. So why it is used? It is used to control postprandial hyperglycemia. So what do you mean by this is like, no, postprandial hyperglycemia is nothing but after taking this food, your glucose is getting controlled. That is known as postprandial hyperglycemia. And look at this baseline value over here, right? This is about your basal insulin. So this is basal insulin. Okay. So remember, like insulin is not only released whenever I take the food, insulin will not get insulin is released. This is also like, so suppose imagine I am not consuming the food, even my body will release some amount of an insulin. So that is known as basal insulin. Okay. So now you came to understand what do you mean by this basal and bolus. Bolus is something like after having the food, insulin is released, that is bolus. like there is some base insulin, right? If even though I don't have my food, the insulin is released in the body, so that is known as basal insulin. So what is the main function? Bolus though we know, like it is used to control the postprandial hyperglycemia. Basal though it is used to inhibit catabolism. I thought, you know, like that's why I thought the mechanism over there, it will put brake on this catabolism. So due to this increase in this catabolism, this part, now sugar is getting elevated in the body. So all these bolus insulin, they are used to control this gluconeogenesis, glycogen and all, right? So this is about basal and bolus insulin. And next is like, why insulin cannot be given orally? Can anybody comment in the comment section why insulin cannot be given orally? Why? So always insulin is given by through subcutaneous route, right? Or in an emergency we can give IV also. I will be teaching types of insulin also. Okay, let's start our discussion. Like let's move on to our discussion. So let me teach you about types of an insulin. So if you look at these types of an insulin, so there are like different types of an insulin. So that is like ultra short acting and all. So come to the discussion, like what is the major type? That is ultra short acting, or it is also called rapid acting insulin. And next is short acting insulin. Okay, rapid, and next one is short acting, and next one is, so let me teach you the duration also. For ultra short or rapid acting insulin, the duration is about 3 hours. Okay, and what name the brands which are name is like Lispro, Aspart and Glulysin. Remember here I will mark the trick over here is yes, everything S is present, so that is like ultra short or rapid acting insulin. And next is like short acting insulin. What is the duration of short acting insulin is 6 hours. So this is also known as regular insulin, right? So this is a regular insulin. And next we move, this is the, and remember, like this is the insulin which we can be given IV by through the IV route. Okay, this is the insulin which we can be given in IV. So that's why it is used in case of an emergency such as diabetic ketoacidosis and all. And next is intermediate. So what is the duration over here is 15 hours. So the acting will be like this. Okay, so best example is NPH. So that is your neutral protamine hagedron. Okay, this is about intermediate acting insulin. Remember, like for insulin, for regular insulin, zinc is added. Why? It will increases the duration. Okay, so this is the reason why zinc is added. So like you can be seeing like zinc is added to the insulin. Why? It makes insulin long acting. So this is the reason why zinc is added to the insulin. So like next we move to the long acting insulin. So duration is 18 hours. Best example over here is Detamir. And if the duration is 24 hours, the best action is Glargine. Okay, so here I taught you know in regular insulin zinc is added. Here what is added? So remember, whatever molecule you are adding, whether it is in zinc, whether it is in fat, all they are added to increase the duration, right? So remember, the duration of Detamir and Glargine is like 18 to 24, and it's like extremely long acting insulin. No, so like something should be added to it. So here I will be adding fatty molecules, right? So what happens, actually what happens, no, insulin will come and bind to this fatty molecules. Okay, Same here also, insulin will come and binds to this. So that's why after binding in the blood it should act. So that's why for degradation or from coming out from this, right, it requires some time. So that's why it is long acting. For separation it needs some time, no. So that's why this is a long acting insulin. And next we are having ultra long acting insulin. So duration is 42 hours and example is degludec. Okay. So remember, all these are peakless insulin. Long acting insulin, they don't have peak. So that's why, like, which is the longest acting insulin or ultra long is like which acts for too much period is like this. Don't answer glargine. If you have degludec, you can go for this degludec. If this is not there, you can go for glargine. And if this is not there, then you can go for detamir. And I will teach shortest acting also, order of shortest acting or rapid acting in onset. That is, yes, not Lispro, that is your Afrezza. I will be showing the image also. Afrezza is a nasal insulin, that is a shortest acting insulin. Then you can go for one more also, that is Lispro. Okay. So this is about shortest acting insulin and about insulin types. So these are all about insulin and durations and types also. Like one more point I would like to add, very important regarding insulin. No. So rapid onset, rapid insulin, and this is like regular wala, and this is an intermediate acting insulin. Okay. And this is like something which is longest acting insulin. So this is rapid, first one, and this is regular, and this is intermediate, and this is an long acting, and this is an ultimately longest, ultra long. Okay. Degludec. Remember, rapid and regular insulin, they are like rapid in onset, no. So that's why they are used as bolus insulin. You all came to know what do you mean by the bolus insulin. I have explained in earlier also. Bolus is nothing but which is used to control the postprandial glucose. So that's why it is used to control postprandial hyperglycemia. So that's why it is used before meals. Right, this is used before meals. And all these like basal insulin, this NPH, long acting, these are all like basal insulin. Okay. And remember, like this mixing, never combine these insulins with this longest acting. Okay. Suppose, imagine like you should be always, there should be a combination between this basal and bolus, no. Like if you are giving like insulin, that should contain like that should treat both the postprandial and your baseline also. So like it should put brakes on both the things. So like you cannot control things. That's why there will be a basal bolus regime and all, right. So remember, you can mix NPH with rapid acting insulin such as lag, Lispro, aspartame, glulysin, and you can mix with regular also. Okay. So why? You can mix all this in the same syringe. Why? Because they are having the same pH. That is also neutral pH. Okay. So that is your 7.2, and you should never combine this NPH with, so why like no? So this NPH, it contains the basal dose, so it will maintain this baseline. So this rapid, it is a basal bolus regime you can use, right. So you cannot combine this NPH, never combine NPH or any other insulin with, never combine this ultra short or short acting insulins with glargine or degludec. because their pH is different. They are like, they will leads to acidic pH. So this is the reason why you should not mix any insulins with this glargine or digludac. They are longest acting insulin and their pH is completely different. Okay, so this is the reason. And this device which I am showing, this is an inhaler like Afrezza. This is the device which I told, nasal insulin. This is Afrezza. This is the nasal insulin. Okay, and this is a rapid acting when compared to Lispro, Lag, no, like that is a rapid acting. This Afrezza is a nasal insulin. And next, can you see what is this device? So this device is, just tell me, this is like, remember I have mentioned this is a very important IBQ. This is like, here this is like continuous glucose monitoring. This one, this is continuous glucose monitoring, right? And what is this? So look at this. This is like a cell phone or mobile phone. Like this, here one patch is present. If you bring that monitor to this patch, this will show the blood glucose level. This is like too expensive, and this is like a continuous glucose monitoring. This is like for automated glycemic controller. So look at this. This will measure the glucose. If you bring this mobile phone or cell phone display to this patch, near to this patch, this will show the blood glucose level. Okay, based on this will work. This is known as continuous subcutaneous insulin infusion, CSSI. This device, sorry, so let me see the diagram. So okay, this is the diagram. So which I have marking over here, this is like completely like insulin pump. So look at where the insulin pump is present in this condition. So look at the carefully, this is like here some catheter is present over here. So this is an infusion set and this is an insulin pump. Some catheter is present over here. So what actually happens is like, this mobile will show you the glucose value. This catheter automatically itself they will deliver the insulin, no need to wait also. This is like continuous subcutaneous insulin infusion. This is also known as infusion pump. This is the best method to deliver the insulin when compared to your insulin pens and all, right? So this is the insulin pump over here. So that this is an insulin pump and this mobile is continuous glucose monitoring. Don't answer and come like CSSI, continuous subcutaneous insulin infusion. Okay, this is the best method. So this is about Afrezza and insulin. And what is this? This is about insulin pen. Okay, so this is used in pediatrics group, right? Suppose imagine in type 1 diabetes mellitus patient, the kid is having this diabetes and you are going to give the insulin, the mother, so like he should be taking this insulin continuously, no? The mother will send his dose and he will send it to the schools, so he can self administer this. Okay, so this is about insulin pen. And now let's study about adverse effects of an insulin. So like we all know insulin will cause us what? Hypoglycemia. It also causes weight gain. And it also causes hypokalemia. And it also causes lipodystrophy. So what do you mean by this? Abnormal fat growth. Okay, these are all about adverse effects of insulin. And now this is very important, Somo-Guy phenomenon and Dawn phenomenon. So what actually happens over here is, listen carefully. So most of the students, they will be confusing over here. So this is night 10 p.m. and this is early morning 4 a.m. or late night hypoglycemia, and here it is like early morning, sorry, it is like 7 a.m. I have ordered 10 units insulin, and for like diabetes mellitus, type 1 diabetes mellitus, and mother read this 10 as 16, or she made this 10 as 19, and she gave 19 units insulin to the kid. So what happens is like, at night it was 150 mg per dl. Due to this high dose, no, she is giving, instead of 10, she is given high dose. What happen if more insulin? Hypoglycemia. So that's why in the 4 a.m. you will be getting hypoglycemia. Okay. So why? It is a physiological process. So this is a physiological, instead of 10 she is giving 19. So confused between unit insulin dose. So that's why here she is getting like hypoglycemia. Hypoglycemia is present in this condition. So body have this mechanism, no, whenever insulin will become, glucose will become less, the body's own mechanism, that is cortisol, will come to the action over here, and it will increases the blood glucose level. So that's why at early morning you will find the hyperglycemia in this patient. This is early morning hyperglycemia and nocturnal, at night time or like late night hypoglycemia. So late night you can find hypoglycemia. Okay. This is about Somogai phenomenon. I think you guys understood about this Somogai phenomenon. And next is like, so what, this is the major why it is happening, like instead of 10 she is giving 19 units. So no, so why glucose is increasing in the morning is like due to this cortisol. And next is like dawn phenomenon. So what actually happens over here is like, at the night 10 p.m. here 150 mg per dl glucose. At 4 a.m. also it is like 150 mg per dl. So like there is no hypoglycemia over here in dawn. And look at over here in early morning 7 a.m. what is happening? Hyperglycemia is happening. So here the different factor between Somogai and dawn is like, in 4 a.m. like here in like which is in late night you will find, or in nocturnal hyperglycemia. Okay, nocturnal this is the major difference over here. Here at night time hyperglycemia, here it is hypoglycemia in this patient, right? So this is about so why it is actually, what it is happening is like, between 4 a.m. to 7 a.m. these GLUT4 receptors, no, they won't function properly. So that's why the person is having early morning hyperglycemia. Okay, here the glucose level will be get elevated in 7 a.m. right. So this is about dawn phenomenon. The GLUT4 activity is decreased between 4 a.m. to 7 a.m. So that's why there is an hyperglycemia. So like if you look at the both this Somogai and dawn is like, you cannot differentiate based on these early morning levels, glucose levels, right. So you can find hypoglycemia there also, here also, but problem is in like nocturnal, at the night time variation. No, look at the dip over here. At the night time there is hypoglycemia, that is Somogai. At a dawn phenomenon there is like hyperglycemia. Okay, so how do you treat? Treatment is like, you should monitor continuous glucose monitoring, which I have told you, know, that diagram also. And next you are going to give continuous subcutaneous insulin infusion, which I have CSSI, which I have taught you earlier. Okay, so this is about treatment aspect, very important, Somogai and dawn phenomenon. So what about dawn? What are the treatment you are going to use? Yes, you should definitely know, you should increase the night dose. Okay, so this is the treatment aspects. And if anybody asks which is the most common site of an insulin, is don't answer arms, right? So it is an abdomen. Most common site of insulin is like your abdomen. This is the most common. And look at, you are giving like 2 centimeters up. This is an umbilicus. You should not give near to the umbilicus. You should give 2 centimeters away from the umbilicus. Okay. So this is about site of an insulin. This is about insulin and types of an insulin, uses of an insulin and all. So most common site, whatever which I have mentioned over here is like abdomen also you can give, arms also you can give, buttocks also you can give, and you can give this upper outer thighs also. But in what side, most of you they will be seeing this like upper arms, but book says like most common site of giving this insulin is like abdomen, like 2 centimeters away from the umbilicus. Okay. And this is about insulin therapy. And next in like 5-10 minutes we'll close the session. We'll go to oral hypoglycemic agents, very important, like where you're going to use. So I will be teaching as a nursing officer, as a nursing student, you should know like in a single word what is the use of this drug and which conditions they are using and their actions also, right? So let's we move to oral hypoglycemic agents. So best example for oral hypoglycemic agents, drug of choice is like your Bigandis, that is metformin. Metformin, what they will do, they will put brake on hepatic gluconeogenesis, right? From liver will also contribute to the production of the blood sugar. So this metformin, they will put brake on that. So that's why the glucose which is produced from the liver, it will not get produced. Okay. So like metformin, wherever it is contraindicated if the patient is having, if GFR is less than 30 ml per minute, and you can see like it is also contraindicated in, yes, tell me, it is also contraindicated in lactic acidosis. Okay. This is about metformin. And next is like semaglutide. So semaglutide, GLP-1 receptor antagonist. So this is also used. Where it is used? Yes, tell. So it is used to decrease cardiovascular mortality, and it is also used as weight loss drug. It is also used. So why this? So remember, nowadays semaglutide use is more because it will, if suppose imagine and heart disease patient has came and he is diabetic, which tablet you are going to prescribe is semaglutide, definitely GLP-1 receptor agonist, right? Semaglutide is the best example for that. Why? It will decreases the cardiovascular mortality in this patient, and it also produces the weight loss. The major disadvantage, it is this tablet is too costly. One tablet it will cost 300 rupees. So like most of the people they cannot, one tablet is 300, it's like too much expensive. So most of the people they cannot afford for this tablet. But this tablet they used in like America and all, UK and all, right? So in Western countries they are using this. So remember, which drug is used to decrease the cardiovascular mortality? Semaglutide. Okay. And next is like insulin secretase glipizide. It is also like, why this is the best example. So why it will act? It will depolarize the beta cells. Okay, it will helps in depolarize. So what is the function of this? Like, so very important is what is the major side effect is, this is the only oral hypoglycemic agent which causes hypoglycemia. So that's why what is the advice you are going to give is like, the person should carry any sugar items if he is taking this glipizide tablet over here. Okay. And next is like SGL2 inhibitors. So what is the main function of this SGL2 is, normally SGL2 it will promote, like it will helps in like sodium and sugar absorption in the body. Okay, it helps in sodium and sugar reabsorption. If I put brake on this sodium, and because in diabetes more sugar is present, if I put brake on this, if I inhibit this receptor, this will promote the urinary loss of sugar, that is glycosuria. Okay, so this is the major function of SGLT2 inhibitor, that is gangliflozin. Okay, so this is also reduces the cardiovascular mortality. So very important, I have mentioned two drugs, that is your semaglutide and gangliflozin or MP. These are the only drugs in endocrinology which reduces the cardiovascular mortality. And next one is alpha glucosidase inhibitor. So best example for this is acarbose. Okay, so what they will do, they from the intestine also some sugar will be produced. They will put brake on that. That is GI absorption of sugar. Okay, so this is the function of this acarbose. Okay, like GI absorption. So very important, and this slide is very important, oral hypoglycemic agents and for one liners also. And this is all about today's session of an endocrinology. And if you have any doubts until now in this session, you can ask me. If you have any doubts, you can ask me or you can message me. Otherwise, I am closing the session. And this is all about insulin, diabetes and all. In the next session, we are going to discuss about all the endocrinology chapter related aspects in the 2 hours. Like I will be completing all the endocrinology in 2 hours. Like that will be very helpful for your Norcet exams. And after that, we will be going for solving the MCQs also. Okay. Okay, I am closing the session. Okay, thank you guys, and thank you for hearing. I think this, if any doubts, you can message us. So you can message in our WhatsApp channel also. If you have any doubts regarding our discussion, I will be handling your doubts and all there. Okay. I hope this session will be helpful for your exams. So next session will be coming up with an endocrinology, complete integrated endocrinology. I will be teaching from physio, medicine, surgical aspects and pharmacological aspects and nursing interventions and all. So thank you guys, and thank you for hearing.